Welcome to the Osteoarthritis Action Alliance Lunch and Learn for April 2015. My name is Kirsten Ambrose, and I appreciate all of you taking the time to join the webinar today. I'm pleased to introduce our presenter, Brian Pietrosimone. Dr. Pietrosimone is the Assistant Professor in the Department of Exercise and Sports Science at the University of North Carolina at Chapel Hill. His research seeks to decrease disability related to knee injury with a focus on maximizing long-term joint health following traumatic joint injury. Much of his previous and current research has evaluated the neuromuscular mechanisms related to disability following lower extremity joint injury. Additionally, he has sought to develop novel intervention strategies to treat neuromuscular impairments and improve clinical outcomes. His future projects look to evaluate how measures of joint metabolism interact with early biomechanical changes following traumatic knee injury for the purpose of minimizing the risk of post-traumatic osteoarthritis development. Today's webinar is titled Neuromuscular Consequences of Knee Osteoarthritis, Implications for Therapy. Welcome, Dr. Pietrosimone.
All right, thank you. Well, first, I'd like to thank the OAAA Action Alliance for inviting me to do this webinar today, and thank you, Kirsten, for your work in setting this webinar up. I'd like to talk about 3 points today. The first is how muscular weakness may actually contribute to disability in patients with knee OA. The second, how neuromuscular mechanisms may give rise to this muscular dysfunction. And then finally, how clinicians may be able to target the nervous system to improve muscle function and decrease some of this disability that we're seeing in patients with knee injury and knee OA. First, I think it's important to talk about this problem in the context of our society. So one of the challenges that we face in advocating for the importance of treating joint-related diseases in our society is that oftentimes the public doesn't see musculoskeletal disease as a cause of death, and therefore musculoskeletal disease may not oftentimes be taken with the same level of seriousness that other disease states found in this figure may be. We see in this figure produced by the Bone and Joint Initiative that musculoskeletal diseases cause more disability than any other disease category in the United States. And while musculoskeletal disease may not directly cause death, it does significantly affect our ability to move, which makes people with musculoskeletal conditions more prone to many other physical and activity-related diseases such as cardiovascular disease or diabetes that directly cause death. If we look at joint-related pathologies are often responsible for causing the most disability among all of these musculoskeletal conditions. And in Americans, knee joint pain is the most common site for joint-related disability. Knee osteoarthritis is the most common cause of knee joint pain worldwide, and knee OA specifically is the 11th leading cause of disability worldwide. It's estimated that as many as 4.1% of the world population may have symptomatic knee osteoarthritis, and the prevalence may actually be higher here in the United States at 4.9%. While the exact amount of dollars spent treating knee OA may be difficult to estimate at any one time, approximately $42 billion is spent annually on treating end-stage knee and hip OA alone, which is, largely a product of total joint replacement. So the median age of knee OA diagnosis is about 55 years old. So therefore, many individuals are forced to manage knee OA for many decades of their lives. While the impact of many diseases is often described by lives lost, the burden of knee OA may best be felt by the number of years lived with disability. So in 2010, knee OA was estimated to cause about 17.1 billion years lived with disability worldwide. And disability for individuals with knee OA is related a lot to the inability to move appropriately, which is linked to difficulty, completing activities of daily living, such as walking or getting up from a chair or ambulating up and down stairs. And many of these activities require a large amount of lower extremity muscle function in order to perform them appropriately. Unfortunately, we see that lower extremity muscle weakness is common in patients with knee OA. Specifically, the quadriceps musculature, which is located on your anterior thigh and responsible for concentric knee extension, is commonly found to be weak in patients with knee OA. And in this case, in the case control studies that have looked at quadriceps strength in knee OA and have also normalized these strength values to body weight, we see that for the most part, the percent deficits in knee extensor strength range anywhere from 3 to 26% compared to healthy matched controls, with many of these studies actually reporting deficits in the teens and 20s. So while some may argue that quadriceps musculature, highlighted here on the right, are only among one group of muscles in the lower extremity, there is evidence that quadriceps strength is critical for producing force needed for locomotion, as well as maintaining critical mechanics responsible for distributing loads around the knee. So because this knee extensor strength is so important for enabling activities of daily living, we see that quadriceps strength is actually a good indicator of disability and quality of life for many chronic diseases, including chronic obstructive pulmonary disease, coronary artery disease, diabetes. And in fact, we see that quadriceps strength actually predicts mortality in patients with chronic obstructive pulmonary disease. But to get back to our patients with chronic knee injury, we've found that people with knee OA who often report less leisure time exercise also have weaker quadriceps. And when we've dichotomized this group into patients who report being highly active and those that report being less active, the patients that report being less active actually have significantly weaker quadriceps strength. Licovanio and colleagues actually demonstrated that patients with knee OA, that increased strength of the quadriceps in this group actually associated with better performance in activities that are commonly reported to be difficult in people with knee OA. So increased strength actually associated with increased distances during the 5-minute walk, or faster get up and go times, faster sit to stand times, and faster speed walking up and down stairs. And we found that quadriceps weakness is also common in acute and traumatic knee injury. So even in minimally invasive orthopedic surgeries like meniscectomy, interlimb quadriceps strength deficits can be actually seen 4 years following arthroscopy. And in ACL reconstructed patients, we see it with a mean of 5 years post-surgery. We found that quadriceps strength actually predicts 61% of the variance in their self-reported disability. And it should be mentioned that these acute traumatic knee injured patients not only exhibit persistent disability, but they are also at very high risk for developing rapidly progressive knee OA. So specifically, 1 in 3 ACL reconstructed patients are likely to demonstrate the onset of radiographic knee OA within the first decade following ACL injury. So while quadriceps strength alone may be a good predictor of disability and dysfunction following a knee injury and in those with knee OA, a measure of neuromuscular quadricep activation has previously been shown to moderate the relationship between quadriceps strength and disability in individuals with knee OA. Thereby, patients with lower strength and neuromuscular activation will have the most disability. And what I mean by neuromuscular activation is not the same as strength. Neuromuscular activation, or oftentimes called voluntary activation of the muscle, refers to the ability of the central nervous system, which pertains to the cortical regions of the brain and the spinal reflex pathway excitability, to basically appropriately turn on the muscle, either via recruitment of motor units or increasing the frequency with which those motor units actually fire. So here I have what I think is a good example of diminished neuromuscular activation. On the top video, a patient is performing quadriceps contractions a few hours prior to an arthroscopic procedure in the knee. And in the bottom video, we have the same patient 18 hours following arthroscopic meniscectomy. So while the quadriceps muscle was untouched during the surgery, the damage or swelling to the knee joint actually causes the central nervous system, which is, the brain and spinal reflex system that's displayed over there to the right, to inhibit the neuromuscular activation of the muscle. So while this acute process is likely a protective mechanism to decrease forces acting around an injured joint, the persistent neuromuscular deficits can contribute to muscle weakness and disability long term. So patients with knee osteoarthritis demonstrate levels of quadriceps activation that are lower than healthy match control. So here we see that patients with unilateral knee OA, marked in red right here, are only able to activate or turn on about 80% of the quadriceps during a maximal muscle contraction. We see this is much lower than age-matched controls without knee OA that are highlighted in blue there, that are able to activate closer to 90%. Interestingly, and why we oftentimes will use acute traumatic knee injuries as a model, is that these young patients with acute knee injuries, such as ACL injury, marked in the green box there, demonstrate activation deficits that are similar to older patients with knee osteoarthritis. These neuromuscular activation levels are, again, much lower than young control individuals, people without any type of knee injury, marked there in purple, which can activate as much as 95 to 100% of their quadriceps musculature during a maximal contraction. So previous evidence on whether having quadriceps weakness is actually a risk factor for developing OA has been quite contradictory at times. But a recent meta-analysis has provided some clarity on that. So published earlier this year in Osteoarthritis and Cartilage, Oistat and colleagues actually compiled 5 cohort studies that evaluated quadriceps strength initially in people with no evidence of radiographic or symptomatic knee OA. And then they performed follow-up tests at least 2 years later to evaluate the development of knee OA. And overall, there seemed to be higher odds to developing knee OA or osteoarthritis in people with weaker quadriceps. And those odds seem to be higher and actually a little bit more definitive if we look at the confidence intervals in males compared to females. The mechanism linking quadriceps weakness and knee OA remains unconfirmed, but the hypothesis is that increased knee extension at heel strike during gait is linked to the inability to eccentrically contract the quadriceps. So an ability to essentially contract the quadriceps at heel strike may decrease the amount of bend or flexion at the knee, which may decrease or affect energy attenuation or shock absorption at the knee joint. Thereby, patients with weak quadriceps may adapt a more stiffened knee at heel strike, which may increase shock at the joint and potentially hasten the breakdown of different tissues within the knee. So we see a pretty strong association between strength and muscle activation. So when a knee is injured or swelling, the decrease in muscle activation will associate very strongly with the decrease, the subsequent decrease in quadriceps strength. Fortunately, improving quadriceps activation with therapy positively impacts the ability to regain strength, both in ACL reconstructed and knee in patients with knee osteoarthritis, suggesting that improving quadriceps neuromuscular activation would improve quadriceps strength gains in patients with knee OA and knee injury. So a good question at this point may be, is the standard care of therapeutic strengthening effective in patients with knee OA? So if we just look at strengthening exercises compared to doing absolutely nothing, a recent systematic review, a Cochrane review, has updated some of the evidence surrounding traditional land-based therapeutic exercise for improving physical function and pain in patients with knee OA. And they included 54 studies with over 3,500 OA patients. And 45 of those studies, they were considered high quality. And the authors report only a moderate effect for immediate benefits in physical function and pain from therapeutic exercise, and only a small effect in long-term improvements in studies that included 2 to 6 month follow-ups. And based really just upon the upper limit of that 95% confidence interval, did they suggest that maybe there's potential for a minimally clinically important difference in these outcomes. So there may be some benefit shown overall in doing strengthening exercises, but right now this recent Cochrane review has shown that it's not really more impressive. The effects are not more impressive than non-steroidal and anti-inflammatory use. So if our goal is to really lessen societal limitations associated with knee OA and injury, if we work ourselves backwards on this disability paradigm, we see that the traditional approach is actually to treat these impairments, such as muscle strength, which may be causing these functional limitations. And if we go back to that previous slide, we see that we actually have a lot of room to improve on what's currently being done. Unfortunately, we do little to affect the pathophysiology related to the neural pathways that may be affected by joint injury. And our suggestion is maybe that we should target these pathways with treatment in conjunction with therapeutic exercise in order to improve our outcomes related to muscle function and disability further down the continuum. And I think there are 2 reasons why we don't already do this. And the first is that we don't really understand how these neural pathways may be affected by knee injury or knee OA. And the second is that we really don't have clinical strategies to treat pathology or disruption within these neural pathways that may be affecting muscle function. So I've worked with a few different students now in the past couple of years to look at some of these issues, and we've studied both spinal reflexive and cortical excitability pathways in people with ACL reconstructions that are at high risk for developing OA. And we know that the muscle can be contracted by initiating cortical excitability pathways, excitability from the brain, or reflexive pathways in the spinal cord. And in order to target the correct pathway within an intervention, it's important to determine if knee injury or disease is causing some type of reflexive inhibition that stops cortical drive to the muscle, or if there's a cortically initiated inhibition that potentially limits reflexive activation of Obviously, both of these would cause some dramatic changes in how the muscle is able to contract. So in some recently published study, we actually evaluated spinal reflexive and cortical excitability in 3 cohorts, basically control participants there on the right with no neuromuscular activation deficits. We looked at ACL reconstructed patients without neuromuscular activation deficits that were basically similar if we looked at their ability to activate their muscles to that healthy control group. They were able to activate 97% of the quadriceps. And in our third group, we were looking at ACL injured patients on the left there with significant neuromuscular activation deficits. Even during a maximal attempt to contract their muscle, they were only activating about 81% of the quadriceps. So in this slide, the yellow bar kind of represents the normal level of reflex excitability that we saw in the control participants with high neuromuscular activation. And what we see is that the ACLR, or the ACL reconstructed group that maintained high voluntary activation there in the middle, that was, they had activation levels that were similar to the control group, also demonstrated an upregulated excitability in their spinal reflexes. They were able to actually heighten their spinal reflexes, potentially to make up, for this injury, and maintain a high level of neuromuscular activation. The ACL reconstructed group without neuromuscular, with neuromuscular deficits, there all the way to the left, was not able to upregulate their spinal reflexes as high. If we look at corticomotor excitability, we saw that ACL reconstructed patients with neuromuscular deficits had lower corticomotor excitability coming from regions in their brain, where the controls, or where the patients without neuromuscular deficits differed very little from the controls. So this information provides us 2 potential targets for increasing quadriceps activation. As we try to increase or maintain high levels of activation in our knee-injured patients, we can either maintain high levels of corticomotor excitability, or actually try to upregulate some of the spinal reflex excitability that we see in these patients. So with this, we're suggesting a new paradigm in joint injury and knee OA rehabilitation. Our suggestion is to actually focus some of our treatments at the level of the pathophysiology, thereby clinically manipulating these neural pathways in conjunction with therapeutic exercise in order to improve these outcomes related to muscle dysfunction further down the disability continuum. So how may we do this? So upregulating spinal reflex excitability may currently be the easiest way to enhance voluntary activation right now in the clinic. So take this representation of the spinal reflex inhibition. We see there's disease or swelling at the knee joint. The collective afferents arising from the knee may actually be interpreted by interneurons as more inhibitory than excitatory, and thereby stop any propagation of a message to contract the muscle. We've used sensory transcutaneous electrical nerve stimulation, or TENS, and applied this to the injured knee joint. Again, we're not stimulating the muscle directly, but we're changing the collective afferents, again, coming from the injured joint. While we're not necessarily changing the amount of inhibitory signal, we're increasing the amount of excitatory signal, which, when it gets to the spinal cord, if there's more excitatory than inhibitory, we allow for a excitation of that alpha motor neuron and contraction of the muscle. So we've tested this hypothesis in a group of people with knee osteoarthritis and neuromuscular inhibition, and we found that after 45 minutes of sensory TENS in that group in the red there, patients were immediately able to increase neuromuscular activation by about 11% compared to a group of patients with knee OA that just sat there and received no TENS. Next, we had 3 groups in a small randomized controlled trial of knee OA patients with neuromuscular activation deficits. And all groups were provided 12 sessions of supervised therapeutic exercise targeting lower extremity strength over a 4-week period. The red group actually performed these exercises with a TENS unit and then utilized that TENS unit 8 hours per day during activities of daily living. The green group here received placebo TENS during exercise and also used that placebo TENS during 8 hours of their normal daily activity. Finally, in that blue group, they only received exercise. And while all groups started only able to activate about 77 to 80% of their quadriceps, the groups receiving TENS in exercise increased to 94% over the 2-week period and remained at that level at 4 weeks. And that's pretty close to what young, healthy patients, people can activate in their quadriceps. So we see that upregulating spinal reflexes may have a dramatic effect on patients with neuromuscular activation deficits and knee osteoarthritis. And interestingly enough, in this group of people, exercise alone did not seem to improve neuromuscular activation. We saw that in this group with TENS and exercise that those increases in neuromuscular activation also translated over to increases in strength. And while not statistically significant in the small randomized controlled trial, we did find that patients that received TENS and exercise had greater effects benefiting decreased disability, self-reported disability with WOMAC score. So TENS is not the only modality that has been used to improve neuromuscular activation in patients with knee injury or OA. We've recently published a study that reviews other modalities that seek to change neuromuscular activation as well as provide potential strength benefits. We've also rated the strength of the evidence for each one of these in this review. There are further modalities that were not included in our review that due to underdeveloped science at the time when we were writing it. But there are some things that are showing promise for exciting the cortical drive to the muscle. Specifically, both vibration therapy and EMG biofeedback are among modalities that we think may be integrated soon into a clinical setting for this indication. So in conclusion, I just want to stress those 3 themes again from this webinar today. The first, quadriceps strength is critical for maintaining quality of life and function in many chronic diseases, including knee OA. Second, improving quadriceps neuromuscular activation may be important for patients with persistent strength deficits that affect function and disability. And third, manipulating spinal reflex and cortical excitability may be an important clinical mechanism for actually treating these strength deficits that may be persistent in our patients with joint injury. So thank you guys for participating in this webinar, and I wanted to acknowledge some of the foundations that have been supportive in these specific studies that I presented today. Thank you.
Thank you very much, Dr. Pietrosimone. That's interesting, very interesting work. And I just wanted to remind people, if you want to ask a question, you can either text it in and I'll ask, or you can press the hand raise icon and I will unmute you so you can ask yourself. I just wanted to make a comment from the very beginning of your talk. I just wanted to thank you in a way for setting the stage so nicely. You set up the relationship between musculoskeletal conditions and disability, which is so important. I know I'm preaching to the choir here, but ultimately that affects the ability to manage, I'll say, more serious illnesses or those with higher mortality, such as cardiovascular disease and such. So pointing that out, I think, is key, not only to emphasize the importance of your own work and the paradigm shift in treatment, but also to be self-serving for the OA Action Alliance mission for public health and clinical settings and treatment. So thank you.
Absolutely.
We do have one question so far from Marty E. Slack. Thank you for a great talk. And how are you measuring neuromuscular activation?
We measure voluntary activation using a superimposed burst technique. So there's a few different ways to do it. People do it a little bit differently, but the technique is somewhat similar. We're using force as almost a surrogate variable for activation. So we use the central activation ratio, where they basically perform an isometric contraction on a dynamometer, and we basically, when they reach a point where they cannot contract their muscle anymore, we provide a brief but strong electrical stimulation to the muscle, which activates the motor neurons that aren't able to be activated voluntarily. And that gives us a way of actually looking at how much of the muscle can they contract versus how much is available to contract if they were able to access all those motor units and fire them at the optimal frequency. Hope that answered that question.
Thank you. So we have another one came in from, yes, actually we got a response on that. Thank you. I'm familiar with the technique. I was just wondering if you had found a way to do this more clinically.
Yeah, I think that's one of the hardest things, is to get people to, buy into doing an activation test, as it isn't the most comfortable. Some people have actually started to use a doublet rather than a train, and I think it's a little bit more comfortable. But as far as setting it up, I think Delaware does a really good job at doing it in the clinic with a lot of their patients. I think you just have to have a little bit more buy-in from your patients and your clinicians to actually get that done.
All right, so we have a question from Conrad Gabler. He says, great job, Brian. Demonstrating the importance that quad strength has on function and quality of life is a constant process. Have there been any studies that used a fatigue model to access the effect the quad weakness has on lower extremity kinematics or kinetics?
Yeah, I'm not familiar with every single one, but there have definitely been fatigue models that have looked at, how that affects, how you move in a variety of different tasks, whether it's running or jumping. I think with neuromuscular activation, I'm aware of a few, one out of Virginia, where they looked at, fatiguing someone or having them do an exercise and looking at how quadriceps activation decreases. And I think they've used actually a few different intervention braces or sleeves to try to, basically maintain quadriceps activation following fatigue.
Great, thank you. So while I wait for any last questions to come in, I just wanted once again to thank you. Actually, I just got a question in from Nicole Catano. We have a great talk, Brian. Have you investigated quad weakness in your post-injury patients and its relationship to self-reported disability or biomechanics?
Yeah, actually, quad strength seems to correlate very highly with self-reported disability, specifically the WOMAC. And this is like a really easy measure of quad strength. We're just using isometric strength at 90 degrees. It doesn't have necessarily the same associations with all of our measures of biomechanics, whether it's in gait or jumping, or which are some that we've tested recently. But it seems in pretty much every cohort that we've looked at, whether it's ACL reconstruction, or actually I think I want to say post-meniscectomy. Michelle McLeod just finished her dissertation on that last year, and it also showed to be highly correlated with self-reported function. So that's strength specifically. Activation actually doesn't correlate directly as high with self-reported function, but I think it's going to be like, through strength with which activation correlates, if that makes sense.
All right, thank you very much. So there again, while I'm waiting for any last questions, I'll just make a quick announcement. First of all, to thank Dr. Pietrosimone today. This was a very interesting talk, and I think a good way to think about treatment going forward. So I appreciate you taking the time today, and for all of you listening, much appreciate your taking the time. On May 18th, we have a webinar with Dr. Susan Murphy, who's Assistant Professor in Physical Medicine and Rehabilitation at the University of Michigan. So stay tuned for those announcements or check out our website. I'll announce, you'll see more information about this later today. We have a small grant RFA that's coming out today about physical activity, so keep your eyes out. If you are on our email list, you'll get that later on today, and if you're not, shoot me an email at oaaction@unc.edu to get a little more information. So with that, I will conclude our webinar for today, and once again, thank you to all of you for tuning in and to Dr. Pietrosimone. Much appreciated.
Thank you.